at St. Luke's Hospital and her residency at McLean Hospital in Belmont, Massachusetts. Dr. Yonkers is currently the Katz Family Chair of Psychiatry at UMass Medical School. She's a physician scientist, and her impact on the field of mood and substance use disorders in women is substantial. She has conducted numerous studies supported by NIH. These projects have focused on exploring optimal ways to identify, engage, and treat mood disorders and substance use disorders in women. For example, in a cohort of 2,700 women, she mapped the course of mood, anxiety, and substance use disorders and examined their relationship with adverse birth outcomes. She devised and tested behavioral and pharmacologic treatments for perinatal women with substance use disorders. Leadership has been a critical component of Dr. Yonkers' career. She has chaired permanent and special grant study sections for NIH, was a member of the task force for DSM-5, and you're gonna, no? Oh, she's gonna, she's gonna have important leadership positions in the future. She served as president of the North American Society of Psychosocial OBGYN, chaired the Women's Committee for the American College of Neuropsychopharmacology, and participated in planning committees for biological psychiatry, the American Society of Clinical Psychopharm, and the International Association of Women's Mental Health. As you know, she is an active educator and mentor. She's the author of more than 150 publications, 26 chapters, and 2 edited books. Among her invited lectures and awards are those from the APA, the American College of Obstetricians and Gynecologists, and the Academy of Consultation Liaison Psychiatry.
Thank you so much. Well, I will just say that the state of the department is strong. And I'm sorry I don't get to go on and tell you about all of the wonderful things people are doing, but we can save that for another time. And I want to thank you all for attending, although it feels like the shift is sort of leaning on this way. So if people have trouble finding space up there, there's plenty of room to the left of me. So let me begin by just mentioning my disclosures. So I receive royalties from Up to Date, which is an online medical encyclopedia, current grant support from PCORI, NIAAA, NIMH, and past grant support from NIDA, CDC, and NHLBI. So I'm going to just briefly give you sort of, if you will, a bit of a rundown of my greatest hits, which is some of the research that I've been fortunate enough to be funded to do and work with a great group of researchers. And that will include information on the epidemiology, screening, course, and treatment of perinatal individuals with substance use disorders. So these data are from the National Survey on Drug Use and Health, which is a really important epidemiological database that we often rely on. And there is a lag, so these are 2020 data. And it's really kind of interesting because I think in terms of the prevalence of use, substance use in both pregnant and non-pregnant individuals, as well as substance use disorders, we started to see things trend in a positive way. And I'll show you some more of those data, but unfortunately, and it may be because of the pandemic and all of the issues related to the pandemic, it's not so great. So what we currently see is about nearly half of women with substance use disorders struggle with illicit substances. 7 in 10 struggle with alcohol use. And I just want to, I do want to put a little footnote in here, which is a lot of times there's emphasis on the opioid crisis, and we have just not one pandemic, we have 2 pandemics. Alcohol use disorder remains the #1 killer. Opioids is inching up in terms of substance use disorders, and women are disproportionately affected by the increment in that particular substance use disorder. And then 1 in 7, or nearly 15%, struggle with both drugs and alcohol. So that's a substantial proportion of the population. So we see overall 13% of people aged 18 and older have a substance use disorder issue, and 9.5 million have both a substance use disorder and a mental illness. Now, I did just mention that it looked as if things were trending in a positive way. These, again, are National Survey of Drug Use and Health data, and these are cross-sectional self-report data, so there are some limitations to it. But you can see, and let me see if I can figure out how to do this. So you can see why I said that actually it looked like rates of certain use disorders was decreasing, like here's alcohol, boom, the pandemic, and here's illicit drugs, boom, the pandemic. Tobacco has actually been a success story. It's been one of the most, I think, successful public health campaigns in terms of reducing the use of tobacco. Of course, this doesn't necessarily include a lot of the vaping. And then we're seeing this really interesting, this is among pregnant individuals, by the way, we're seeing this very interesting uptick in the use of marijuana during pregnancy. And I think that has a lot to do with the legalization in various states. Opioids are still relatively low, although the impact, of course, is substantial, and especially some of the newer compounds like fentanyl and carfentanil are really can just be absolute death sentences. And there's a bit of an uptick in cocaine as well. So this is daily or almost daily marijuana use. And I think, it's not surprising given the legalization that we're starting to see this, but the data are really not particularly reassuring with regard to birth outcomes among individuals exposed to cannabis in pregnancy. So this is something, there have been some large-scale epidemiological studies, and they sort of looking at birth outcomes like preterm birth, low birth weight, and they sort of fall on both sides of the story. Part of the problem is that a lot of people who use cannabis also smoke, and we know that that's a perinatal teratogen, or that's redundant. That's a teratogen. So I think people are turning to marijuana, but it's something we need to watch out for. Now, I mentioned that some of the what we're starting to see with alcohol is a little bit worrisome, and I just want to reflect on this little blip in this here. So while you're seeing some trends showing things are improving, not necessarily in pregnancy. So, one of the things that I will discuss when I see, for example, an individual who's pregnant and they're coming in for a consultation about what to do with their antidepressant or antipsychotic, is I always ask about alcohol, smoking, other recreational drugs, because those compounds are at least as bad, if not worse, than most of our prescription medications. And we need to make sure that we're educating our patients when we talk about various exposures. Now, the limitation for the National Survey on Drug Use and Health is its self-report, cross-sectional. These data are from Utah, and they're actually biologically verified. And I think it paints a pretty worrisome picture. Now, it could be that, who knows, maybe pregnant individuals who use substances all of a sudden have decided that Utah is the best place to live. And so they've all moved over to Utah. I kind of doubt that, although, the mountains in Utah are great and skiing there is wonderful. But when you look at the historical numbers here and then the more recent numbers, it really is pretty problematic, just in terms of any substance, but also opioids in particular, not surprisingly, marijuana and amphetamines. So, and those are biologically verified. Now, this slide reflects something I think that worried a number of people in terms of mortality risk. Unfortunately, the United States has one of the worst perinatal mortality rates of developed countries or Western countries, if you will. And one of the reasons is probably related to substance use. So what you can see here is the mortality risk rate among pregnant individuals by race and ethnicity. But the other sort of big take home, in the light blue, you see extreme likelihood of dying among those individuals with a substance use disorder. And then the dark blue are individuals who do not have a substance use disorder. And Asian or Pacific Islanders is really remarkably high, but it's also pretty worrisome in other populations, including, Native Americans, Hispanics, whites, whatever. So just being pregnant and having a substance use disorder automatically puts you in a much higher risk category for mortality. We're not even talking about complications. We're talking about death in that particular instance. So with that background, I wanted to talk with you a bit about some of the work that my lab has been doing over the past, 10, 15 years. And let me start with where we would like to begin, which is screening individuals for a substance use disorder during pregnancy. And one of the things that we, until recently, did not have is we did not have screeners that were specific for pregnant individuals. And you may ask, why do we need that? Why can't we just use another screener? And maybe other screeners that are or case finding instruments, if you will, are effective for this population. But this is a very stigmatized behavior in individuals. And so the likelihood of self-disclosure is diminishingly small for some people. So there are ways to screen that are just for, are you using, if you will, and then there's some other sort of more subtle ways to screen. And we've looked at various screeners. So this particular study was funded by the CDC. And what they wanted us to do was to look at the rates of substance use in a diverse cohort. And I want to underscore diverse because, and I want to underscore diverse, but I also want to say it's not, they wanted a diverse cohort, not in the way that we usually think about diversity. So we usually think diversity, the baseline white group of people and add people of color, right? Unfortunately, for substance use in pregnancy, the fallback had been to look at individuals of color and assume that they were at higher risk and to not screen the white individuals who are pregnant, when a couple of studies suggested that it's just as problematic for white individuals as for those who are not white. So there was a little bit of racial bias, a lot of racial bias in the wrong way. They also wanted us to compare the performance of various screeners, including the few screeners, one of which I developed, that were specific for individuals who were pregnant, and then to take a look at, to use some more advanced statistical modeling to see if we could come up with a short screener that might perform better than what's already out there. So I just mentioned this, substance use in pregnancy is particularly stigmatized. Measures do vary by their propensity to identify individuals with substance use disorder. So, there's some that are more acceptable. People are probably more willing to admit to using marijuana than cocaine, or use tobacco than opioids, et cetera. And given the unique experience of pregnancy, these measures really needed to be tested, and they needed to be tested across pregnancy, right? Because behavior in the first trimester is not necessarily the same as behavior in the second trimester and third trimester. And I'll show you some data on that. So this was a 3-site study, and we assessed a little bit over 1,200 pregnant individuals. We administered 5 screening questionnaires, the SERPI, which is an instrument that I created, the CRAFT, the WIDES, and I'll go through these, the 5 Ps, NIDA, quick screen, and they were administered in counterbalanced order. We obtained consent and confidentiality, but not necessarily anonymity. and I'll talk a little bit about that. Participants were informed that the study was anonymous, and then they were asked about the comfort with the questions and invited to provide a urine sample to test for a range of substances. So one of the reasons, let me just go back here for a sec. One of the reasons step 2 said anonymity is because we were concerned about testing screeners in an experimental setting that didn't reflect the real world. And the real world is if somebody comes into their OB's office and they're asked about the use of substances, they're going to be followed by that individual for pregnancy. They may not want to admit it because it may be embarrassing to them. And it may be that in a study, they would be willing to admit it because they know we have all of these protections and the data would be anonymized. So what we did was a little bit of a slight dose of deception, which I will say the Brigham didn't like, so they didn't buy in for this, but a slight dose of deception, which was we told people this would be confidential, but we did not say it was absolutely anonymous. And in reality, it was absolutely anonymous. And at step 2, we tore up their consent form so that they knew that this was absolutely anonymous. But that way we could sort of try and gauge more real life circumstances, but it certainly is not the same as real life circumstances. So this is the 5 Ps. Did any of your parents have a problem with drug or alcohol use? Do any of your friends have a problem with alcohol or drug use? Does your partner have a problem with alcohol or drug use? And then before you were pregnant, did you have a problem with drug or alcohol use? In the month before you knew you were pregnant, did you drink any beer, wine, or liquor or use other drugs? The substance use risk profile in pregnancy has 3 questions. Have you ever smoked marijuana? In the month before you were pregnant, how many beers, how much wine, or how much liquor did you use? And any was scored as 1. And have you ever felt you needed to cut down on your drug or alcohol use? So that's a bit of a severity question. The craft was really designed for adolescents who had alcohol use, but has also been used by one of our investigators from the Brigham who does some perinatal research, and she used it in a cohort. So we included that. Have you ever ridden in a car driven by someone who was high or had been using alcohol or drugs? Do you ever use alcohol or drugs to relax, feel better, or fit in? Do you ever use alcohol or drugs while you were by yourself alone? Do you ever forget things you did while using drugs or alcohol? Do you or your family or friends ever tell you that you should cut down? Have you gotten into trouble with alcohol or drugs? And then the Wayne indirect drug use screener is more of an implicit. So I mentioned before that, there are 2 approaches. You can just ask people and see what they say. And then are there other ways that other questions that are not direct asks that may give you some sense of whether an individual uses drugs? And so this is all developed by correlation, which is why item number 2, in the past year, I've been bothered by pain in my teeth or mouth. I have to say, I saw that question. This was one of the questions that we used to ask as interns when we thought our patients were not being forthright with telling us things. So this is really to say that this is absolutely corollary, and that may be a measure of the fulsomeness of some of these reports. But the questions are, I'm currently married. I have smoked at least 100 cigarettes in my entire life. Most of my friends smoke cigarettes. There have been times in my life for at least 2 weeks straight where I felt like everything was an effort, and I get mad easily and feel a need to blow off some steam. And this was developed at Wayne State with a inner city population in Detroit. And then the NIDA Quick Screen, which hopefully everybody knows. It's on the NIDA Med site. It's directly just asking people. NIDA, the first question is, in the past month, have you had 4 or more drinks? Have you smoked tobacco products, prescription drugs? illegal drugs. And then what we did is, again, to address the stigma, we asked that for a time period before pregnancy. So in other words, we know you're not doing this now, but did you do it prior to pregnancy? So this was our patient population, and this was by, or the study cohort, this was by design. So we purposely selected a more private practice, commercially insured group of primarily, well, it's not on here, but wealthier white individuals. And then we had an inner city Detroit, which was far more diverse, more likely to have public insurance. And then Yale, we had 2 clinics, and we were sort of right down the middle. What we also tried to do is we tried to assay people in the first trimester, second trimester, and third trimester. So this is cross-sectional, but we wanted roughly a third of the cohort in each one of those time periods, because behaviors, especially, the utilization of substances, changes across pregnancy. And I'll show you some data about that. And these are just positive urine or self-report, which, I'll ask you to just look at this last line. For any substance, remarkably high, right? 18.6, 48, and 31.6%. So now, not surprisingly, alcohol and cigarettes were high, but THC was pretty high as well. So there's a lot of substance use out there, regardless of the population. And these are the measures of merit for the various screeners. So what we really saw, and I'll ask you to really probably the one to look at, is here accuracy. Most people know that sensitivity and specificity sort of fight with each other. If you get better sensitivity, usually specificity is lower, but accuracy takes that into consideration. So the NIDA, the direct asking, actually had the greatest accuracy. It was 80%. And pre-pregnancy did a little worse. Actually, it was 74% roughly. But as you look at these various screeners, I think you also need to ask the question of, what's your goal? Do you want to make sure that you don't miss anybody? Because if you want to make sure that you don't miss anybody, then you want to go for sensitivity, right? However, in pregnancy, with substance use, with reporting issues, yada, 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 you may do harm if you're really sensitive and not paying attention to specificity, right? Because you may identify somebody as using, DCF gets involved, the whole deal. So, specificity may be number one on your list instead. So the data are out there. Now, tobacco use is so highly comorbid with other substance use. It's the most commonly used substance other than alcohol intermittently. So we analyzed the data and we excluded tobacco, and really the results were not changed in terms of very much. I mean, there were some changes, but the NIDA quick screen still had the best performance, although results were attenuated a bit. These are the results of recursive partitioning analysis, which is a classification tree approach. So it's basically machine learning. So it's a kind of dumb approach. It's not a fancy statistical approach. You basically take your data, you put it into the machine picks out, you ask it, the machine picks out the most salient question to break down your cohort into yes or no. Right. So the most salient question for this cohort was, the most informative question was, in the past month, how often have you used tobacco products? And it broke down to never or more than once or twice. So that really identified, most of the risk within the entire cohort of 1,200 plus individuals. And then for the people who said never, there was we were able to pick up a few more, in this instance, really 24 people by asking if they used illegal drugs. So these would be people who didn't smoke but used illegal drugs. So it's small in comparison to what you see here, which is over 1,000 versus 147. So, if you were going to ask one question to pregnant individuals to kind of get a sense of risk, it's probably, do you smoke? And then if they say no, then the next question you might ask is, have you, in the past month, have you ever used any illicit substances? And that's really going to identify most of the individuals that may need some further evaluation. These are just the statistics on this. These are the Akaki scores. And what you see is it just explains the variance. The lowest score is the best. And actually our little CART screener, the recursive partitioning analysis screener, did pretty well when you look at the Akaki's information. So that's kind of nice. And it tells us, if you don't have time to ask anything, and if you're concerned about insulting somebody by asking them if they use any substances, just ask them about tobacco and then maybe use of any recreational drugs in the past month. So the overall performance of the screeners, these are our findings, vary depending on the particular measure of merit. And again, one of the things that I will often talk to people about when they're putting in grant proposals or even writing a paper is, what's your question? And that's really what this says. So the most important finding for you is really relies on what your question is. The NIDA quick screen and the 2-item questionnaire about use of tobacco and illicit substances really had the best overall performance. And screening really can be conducted quite efficiently with few adverse consequences. So, which is good news. Now, I want to talk a little bit about course of illness. And I alluded to that. One of the things, as you may recall, I said is we assayed people for that prior study at 3 different times of pregnancy. And the reason that we did that is largely due to this. So one of the things that you see, and these are old data from the National Survey on Drug Use and Health, but it really, I think, sparked a lot of questions in my mind, even though this is 2003, it was 20 years ago. Time flies when you're having fun. So these are abstinence rates, right? So flip it, these are not use rates, these are abstinence rates. So the lowest rate of abstinence is here during the first trimester. Makes sense, right? Because a lot of people don't know they're pregnant. They may have irregular menses, especially if they're drinking or if they're using other substances, and the line all of a sudden turns blue, and then boom, the abstinence rate goes up because they realize what's going on here. Or they may have had a prior experience when they were pregnant and had an adverse outcome. And then by 3rd trimester, the rates go up. Unfortunately, post-pregnancy, things go down again. So kind of interesting that there is this difference. For hazardous substance use, it decreases throughout pregnancy. Smoking a little bit less so, and I'll show you some data on that. About 80% of postpartum women relapse to drug or alcohol use after delivery. And I'm just going to drop the seed, and I'm going to talk about this toward the end of the time together. But think about it. We always talk about pregnant women not using substances because they don't want their fetus exposed to substances, right? They want to be a good mother. They still want to be a good mother after they deliver. But now they don't have all of these gonadal steroids on board. The 10-fold to 50-fold in the 3rd trimester increase in progesterone and estradiol. So I'll talk about a little bit more. That's a little bit of a teaser. Illicit substance use and heavy alcohol use have both physical and cognitive effects on offspring, and they influence optimal maternal care. There's lots of reasons to get our hands around this problem. So one of the studies we did was called the Pride in Pregnancy study. And this was an RCT. What we did is we recruited pregnant individuals, and we had someone providing treatment in their prenatal care center. And the treatment was really motivational enhancement therapy. So not motivational interviewing, which is usually one session with maybe a booster, but MET is more of a 4 to 6 session intervention versus brief advice. And the brief advice was given by their obstetrical provider. So when we did this, which was ages ago, it was the first systematic randomized controlled study to look at relapse prevention therapy for individuals who were pregnant. And part of the novelty at that time, which was 15 years ago, was it integrated substance use treatment alongside usual prenatal care. We were fortunate enough to be able to follow people for 24 months post-delivery, and so we have some really nice longitudinal data. These were our methods. We included people up to 28 weeks. They had to be age 16 or older. They had to have a positive tweak, a different screening instrument, or the 4 Ps, not the 5 Ps. And then they were randomized to 6 sessions of MET CBT. Oh, I neglected to say that we combined motivational enhancement therapy with CBT, and we shortened it, cognitive behavioral therapy. So it was a combined treatment. They started off with MET and then rolled into cognitive behavioral therapy, and that was versus brief advice. And everything, of course, was audio taped, and we did fidelity, and people were supervised on it. We did assessments at intake 28 weeks and then 3 months postpartum. And then we received another grant to continue to follow people out to 2 years. We also collected the timeline follow back and a urine tox screen when we could. This was our cohort. We had 92 individuals who received brief advice and 91 who received the MET CBT. The groups were roughly comparable to each other. There were slightly more individuals who were African American in the MET CBT group, more people of Hispanic ethnicity in the brief advice group, but high rates of substance use. So I should say, MET CBT did not differ from control, and that is because, as you saw in that cross-sectional data from the National Survey on Drug Use and Health, people tended to get better and get abstinent. And these are data from our study, which was longitudinal and biologically verified, showing that, in fact, over time, the rates of abstinence accrue. But what we were also interested in is differences among the various substances. So you see here, this is the alcohol curve. So alcohol actually improved at a higher rate than the other substances. And we think that might be attributable to some of the warnings that you see on bottles, do not use in pregnancy and da-da-da. Here we have cocaine, which had a pretty steep increase, and marijuana here. And then, if I had one of those sounds, I would do it, but I don't have like a machine that does that. And here is, unfortunately, smoking, which was pretty flat. I like to think that some of this might also be, and we couldn't figure out really how to statistically evaluate this. One of the things in substance use field is how addictive is a substance, right? And, when I look at these data, it just makes me think that tobacco may be one of our most addictive substances. And this is illicit substance. It's not illicit. So we tend to worry about opioids and cocaine, but look at people just could not stop tobacco. And if you talk to individuals who will use several substances, even in pregnancy, they'll say, I gave up heroin, I gave up cocaine, I gave up whatever. Just let me have my cigarettes. Just let me have my cigarettes. And then there are the people that have somebody as soon as they are rolled out of the labor room who want a cigarette, like right then. I mean, it's just amazing that we really need to give tobacco in pregnancy its due, because it's pretty tough. All right, is this not going forward? It is not going forward. Let's see. Maybe you can help me out here.
Oh, I think it just has like a couple.
Oh,
Those are
okay.
appearing now.
All right, thank you. All right, so. Oh, I see. Okay. So in addition to looking at time to abstinence, we also, whoops, it didn't do the same thing. We also looked at time to relapse, right? Because you saw the data that I showed you early that relapse was particularly high as soon as people delivered. And again, thinking that this may be a window into what's the various addictiveness of the various compounds. But so alcohol, actually it was cocaine that had the lowest rate of relapse. You know, I would have not anticipated that. And here's marijuana. Here we have cigarettes, and here's alcohol. Alcohol is a little tricky when you're trying to analyze these data because, you know, what's an abusive amount of alcohol, or when do you start counting alcohol as problematic? Is it 1 drink? Is it 5 drink, the NIAAA criteria or whatever? And this was just simply the NIAAA criteria. So the rate of abstinence was lowest for pregnant individuals who smoke nicotine cigarettes. The rate of abstinence was highest for pregnant individuals who drink. The rate of relapse was lowest for postpartum individuals who use cocaine, and the rate of relapse was highest for postpartum individuals who smoke nicotine cigarettes. So putting some of these data together, you know, really screams for the need of intervention. So we've looked at a couple of possible interventions. People probably know about SBIRT, which is screening, brief intervention, and referral to treatment. So that's basically combining screening and then immediate referral for individuals who use substances. And that's a typical approach in general medical settings, although we could probably do more in psychiatry. It's a very simple approach that seeks to reach large numbers of people in a very efficient way. And the brief intervention is typically motivational intervention, 1 session of MI, which may be 10 minutes, maybe 15 minutes, 20 minutes at most. But even if you can get a primary care provider or another provider to you know, do a motivational interview that endures for 10 minutes, that's great. And that would be coupled with referral. So because it's a brief approach, it's more likely to be accepted. It's found to be efficacious for reducing particularly unhealthy alcohol and tobacco use. Now, there is a literature on MI and SBIRT, and I don't want to short shrift it here. There are some naysayers who think it's not effective and it's not helpful, and they are in Boston largely. But there are also people who really support its efficacy. So there's data on both sides of the state with regard to this. So the components of a motivational interview, understanding the primary substance. So can be a little tricky. A lot of times people will come in and they're using 2, 3 substances, and you want them to focus on one of them. And so you would typically ask the individual which one would they like to focus on. Discuss the reasons for using and not using / cutting down, whichever is their goal. Some people want to stop using. Some people want to just cut down on their use of a substance. Provide personalized feedback, ask key questions, handle resistance skillfully, and draw out what we refer to as change talk. So the reasons for making a change to a positive behavior, develop a change plan, and then summarize that with the individual. So in a different project, Project START, we actually used an electronic version of the screening and brief intervention, the MI, and we conducted screening in a reproductive health center, which included both pregnant and non-pregnant individuals. And we also included a group who received a clinician-administered SBIRT, and then we had a control group. So this was actually one of the first studies to compare these two modalities. Now we think computerized intervention, big deal, but back then it was pretty novel. And it was pretty novel to dare to compare it to a human being. So, but the aim of the RCT was to compare SBIRT delivered either electronically or by clinician to just standard care among individuals in a reproductive health setting who had substance use issues. Our outcomes were days per month of primary substance use, post-SBIRT substance use treatment. So in other words, one of the parts of SBIRT is the data actually show that it's often helpful in terms of reducing substance, but the challenge has been it doesn't really help people get to treatment and stay in treatment. So that's really where a lot of the work has been focused on more recently. And secondary outcomes were days of use for substance groups, cost effectiveness, and abstinence rates. And so this is just basically the schema: screening, consent, randomization to usual care, SBIRT, or just standard clinician SBIRT. And then it was just one session, and then 6-month follow-up. So our participants were at least 18 years old. They had an assist score, which is related to the NIDA quick screen, of greater than 4 for any substance other than alcohol. We actually changed the cutoff for alcohol to 11 for non-pregnant and 6 for pregnant. We just wanted it to be a little bit more robust because we didn't want to pick up people who had one drink every couple of weeks, because then we couldn't really look at change because their use was so low. And they use the primary substance at least once per month prior to randomization. This is just an example of what the program looked like. We had a little avatar. This is Petey the parrot, and Petey talks and flies around. And Petey asks these questions he's very humble, and he says, which sentence best describes how you're feeling about drugs? And then the person would identify which one of these. And they could hear this on the headphone, or they could just decide they wanted to move through it quicker than Petey's talking and do it themselves. And this is Petey again, may say, I'm curious, what are the 3 biggest reasons you've decided to make a change? So it's really trying to do what a clinician might do in terms of eliciting reasons to make some sort of behavioral change. But one of the things I think is really powerful, which we may not talk enough about, is the visual component of this. It's not just that Petey can fly around and ask these salient questions and give you some, it's really the pictures that you can see. So this is feedback, how my use compares with others. And, if you see, this is least, this is most, and you're way up here for something that is a problematic behavior, it really has a visual impact. And, the program has other sorts of things like that, like the accumulation of how much money would you save if you didn't smoke cigarettes, for example. And you just see the coins pile up, right? And then all of a sudden you can get a big TV with that. That really has, a very profound impact, I think. So this is just a summary of our cohort. There were about 150 individuals in each one of these groups, and it was a pretty diverse group in terms of both race, ethnicity, but also marriage. And we had about just under 20% of individuals were pregnant. And these were the mean days of substance use stratified by pregnancy status. So these solid bars are the non-pregnant, and the dotted lines are the people who were pregnant. And usual care is blue, and it just performs, even with the error bars, there's a significant difference between the usual care and the 2 SBIRT groups. The head-to-head difference was a non-significance in terms of favorable effect for the computerized intervention over the clinician administered. intervention. So abstinent rates were higher in pregnant than non-pregnant individuals, which is probably why that study that I had done 10 years earlier couldn't find a difference between MET CBT versus usual care, because the rate of abstinence is pretty high in pregnancy. Usual care was associated with worse substance use outcomes in both the pregnant and non-pregnant individuals, and ESPERT delivered by computer clinician were roughly equivalent, although computer was non-significantly better. And this again is just driving home, what we see in pregnancy and the decrease in use during the middle of pregnancy and then this relapse. So I gave you this little teaser before where I suggested to you that, there's this interesting thing that people are always saying about, pregnant individuals want to stop using substances for their babies, but you talk to people after they deliver and they still love their kids and they still want to be clean. It's just a lot harder to stay clean. And there may be a lot of reasons for that, but it may be that one of those reasons is related to the high exposure of gonadal steroids. So we decided to chase that down. And there actually are some preclinical data. So for example, beta estradiol promotes cocaine self-administration in rats and monkeys. Beta estradiol increases behavioral response to cocaine, such as ambulation, rearing activities, condition placement preference. Progesterone, on the other hand, has the opposite effect and sometimes can actually reverse the effects of estradiol. And I know we have some ringers in the room who know a lot about opioids and estradiol and progesterone. So now this is relevant to what we're seeing now with regard to postnatal depression and this brand new drug that has just been approved as a postnatal depression treatment. And that is based upon that progesterone, which is a neurosteroid, is also synthesized in the CNS, and it actually breaks down into other neurosteroids. So, but progesterone has some properties wherein it's neuroprotective, and this is probably by design, right? So the fetus has some protection. And it was thought to be helpful for example situations like there were some data to show that it was protective for strokes or TBI. The big stroke study, unfortunately, was negative. But its metabolites, allopregnanolone, pregnanolone, they really interact with a lot of receptors that are of interest to us, like GABA, glutamate, sigma. And there's some very intriguing, more recent data to suggest that the metabolites may have a profound effect on inflammation. So, we took this finding that people still want to be clean even after they deliver, but it's just harder. And we decided to do a little RCT of pregnant individuals who had cocaine use disorder and see if we could help them stay abstinent or get them abstinent. So this was a 12-week study. I cannot even tell you what it took to recruit 30 pregnant individuals who use cocaine and put them in a 12-week study. And it's just, I will never have a more difficult study to do, I think, in my life. And I say that now, but I probably will. But anyway, 12 weeks of randomized treatment with weekly visits, 3 months postpartum treatment follow-up. We randomized people to 100 milligrams twice daily of oral micronized progesterone, probably wasn't even enough. And then we obtained weekly qualitative and quantitative urine tests. And they were also eligible, if they wanted, to have CBT for substance use, which nobody really wanted to do. Our measures were the breakdown product in the urine for cocaine, the substance use calendar, which is the same thing as the timeline follow back, a cocaine craving scale, a measure of depression, the EPDS, and the Fagerstrom for smoking. So, it was 50 people, not 30. Sorry, it's been a while. So anyway, these are the characteristics of the cohort, and there's nothing that really differentiated the two groups. And this was our finding. So you see, these are actually These are modeled data, but here you see the progesterone group. Here's baseline. So this is the number of days of cocaine use per week. And this was after delivery. And we just really saw a very nice effect of progesterone decreasing the rate of relapse. And here is the usual care group or the placebo group, and it just went up even though they were seeing us. Unfortunately, this study, this R21, we came out with the findings just as the opioid use disorder epidemic was taking off, and NIDA really didn't want to fund anything other than opioid use disorder. But anyway, this was the risk of relapse after delivery. This is a Kaplan-Meier analysis, and you see that the risk of relapse is much higher for those individuals on placebo compared to individuals recently delivered who were given progesterone. So the biological plausibility for progesterone on cocaine use is actually quite strong. And these data suggest that postpartum individuals may benefit from that, even though the sample size was very limited, and that a larger trial someday may be warranted. So I want to say thank you to the many, many people, and this does include everybody who've been involved in these studies, and also to Maria for her assistance in the slides. She always makes everything I do better. So I'm very pleased with that. And I think we have no time for questions because we got in late.
We have the room till 1:30.
What?
Any questions?
Just one brief one. With the evidence that you showed in the beginning about the nicotine use going down, which is a good public health thing, and cannabis use going up, we're seeing the same thing in young people. Do you envision that 2-question screener with tobacco use? I guess, how would you interpret cannabis use, and could that be used in a similar way in the future?
It's an excellent question. I suspect it could. And I think that what you would do is your specificity would go up, but your sensitivity would go down. But it's a good question.
Other questions?
Ryan?
I had a 2-part question, Kim. So one was about the prevalence, and you showed an increase, but said you think it's related to the pandemic. Is there any sort of trend before? Because in many other areas, increases were actually happening before the pandemic. So that's the first question. And the other one was, so there's sort of high abstinence during pregnancy, but on the flip side, there's still plenty of women who are using, and the impact on those kids born is still significant, but it's looking like it's really hard to study intervention.
And it looks like it's getting worse. And it's not just kids, it's the women themselves. I mean, they're the ones also dying, you know. The data did look favorable in terms of decreases prior to the pandemic. And now, you know, this is associative data. It's not causal data. So, but things have gotten worse since the pandemic. But the other thing that's happening is the substances are changing. I mean, they change all the time. So now, like, you don't find people using opioids, illicit opioids, and not having fentanyl in their urine. They all have fentanyl now, which is different than it was 2 or 3 years ago.
Alcohol isn't changing.
No, alcohol isn't changing, but no, you're right. And alcohol use is increasing in women, and it's certainly increasing in pregnant individuals. But a lot of people, including myself, predicted that things in terms of domestic violence and substance use would get worse during the pandemic because people were locked up inside and people were losing their jobs and they didn't have money. And we know that these are things that increase the risk of substance use as well as domestic violence. So,
any other questions?
That was great. 2 questions. First question is the time to abstinence study. The original study, not the progesterone study. Did you assess perceived risk of drug use by the mother? There were a lot of questions associated with why I desire to do something
Mhm.
rather than how I perceive the impact of the drug on my body.
Yeah, we didn't ask, we did have covariates in the model, but we did not ask that question, how, in terms of how they perceive the effect on them. I mean, we try and educate people, but you also.
Yeah, I mean, the subjective perception, though, is, you made a comment about nicotine potentially having.
I know, like face palm, you walk out of the room and you're like, oh my God, you would have been better off using
more
cocaine.
more addictive than the other drugs. But it could all.
We didn't say, for example, you're much better off just sticking with the cocaine.
Yeah. Right. But perceived risk is important.
Yeah. I think the perceived risk is critical. And I think the fact that we have these two illicit substances, right, just says so much.
Yeah.
And you see what's happening now with marijuana. There's this implicit acceptance of the substance because it's legal.
Yeah. Second question. So in the progesterone study, why did you choose to select a cohort of women who are using cocaine?
Because it looked like from our earlier data that, remember I said the relapse rate was much lower for the cocaine group. And also because the preclinical data really focused on stimulants.
And did you measure polysubstance use in that cohort?
Mm-hmm.
Yeah.
We covaried for that in
Okay.
the analysis. Yeah. That's why I showed you the modeled data.
Cool. Thanks.
Other questions, comments? Yeah.
No, the people on the Zoom world can't hear you. There we go.
Going off of question one from over there, I was just thinking too, with the decrease in prolonged abstinence with nicotine, and thinking about what are your reasons for not using. Also, DCF isn't going to get involved no matter how many cigarettes you smoke.
Yeah,
Versus
absolutely.
with alcohol. Like, I think there's a very real fear with it, whether it's with alcohol or even marijuana, even though in Massachusetts it's legal, that if I come back to this, I could lose my kids. You can't lose your kids with tobacco. I think that could be
Some people think you can.
Really?
Some pregnant individuals will say, yeah, they think that they can't even admit to smoking. Yeah.
Even postpartum.
It is a different world.
Once babies are born, do they still have that?
No, not once during pregnancy though.
Right. So I was more talking about the postpartum period. Like,
Yeah.
if I drink too much, and if I'm someone who understands substance abuse to be a progressive relapsing disease, then I'm going to be probably more motivated to stay away from alcohol. Whereas with cigarettes, like, I smell bad, my kids smell bad, but there's no immediate risk of them being taken away. And that's it. That's a really important mediator, I would think.
It is I think so. And I think that really does dovetail on the acceptability issue. Yeah. We don't have this room until 1:30, do we? No, any other questions before? Okay, great. Thank you all for coming. Thank you all for what you do.